Thank you very much for that kind introduction. And thank you to all of you who are in this room to spend your Saturday afternoon to learn about finerenone. I understand that many people may not know about this drug, so I'll try to make it quite simple and try to impress upon you that this is a molecule that can be or that should be part of your practice, especially if you're taking care of people with type 2 diabetes. So we're going to start off with looking at the burden of diabetes. And diabetes, as you know, affects about 100 million people in this country. 40% of them, or 40 million, will go on to have kidney disease, which is about 4 crore people in India have this disease. 2/3 of these people at least will have albuminuric kidney disease, which means you're talking about 3 crore people having kidney disease. And I would say 95% of these people are unrecognized because we are not doing a simple test. If we look at the problem that exists, you see, diabetes takes away about 10, 12 years of your life. And CKD takes away about 6 or 7 years of your life. You put them together, 16, 17 years of your life is gone. If you have type 2 diabetes, I don't need to teach you how to manage it. But if you have kidney disease, you want to be able to detect it early. And the early detection of kidney disease is not based on a blood test. It doesn't require the patient to even go to the lab. Is not to stick the arm with a needle, but simply urinate in a cup, and I can tell you that you have kidney disease or not. The reason is that we have these tiny filters in the kidney, a million of them. They are called glomeruli. And when they get diseased in diabetes, the basement membrane becomes thick, the mesangium gets hypertrophied, the glomerular capillaries get sclerosed, and the earliest manifestation of this disease is the occurrence of albuminuria. This is how we detect people with kidney disease. If you are looking to biopsy these patients, forget it, you're not going to biopsy patients with early diabetes. But if you simply looked at the urine, you will be able to detect the disease. Now, we are here to discuss finerenone, and this is a drug that blocks the mineralocorticoid receptor. And let's go back to what all of you know. You studied mineralocorticoid receptor when you were a medical student. It is activated by targets like aldosterone and cortisol. And when you activate mineralocorticoid receptor, it leads to salt and water retention, increase in blood pressure, and removal of potassium. That's the normal function of the mineralocorticoid receptor. Now, in the disease state where the patient has type 2 diabetes, there is overexpression of the mineralocorticoid receptor, as a result of which it leads to aberrant effects. Not only it's retaining salt and water and removing potassium, but it leads to inflammation and fibrosis by activating certain things in the nucleus that leads to an aberrant response and leading to the demise of the kidney that we talked about in the previous slide. Here's a little bit more detailed look at the mineralocorticoid receptor. I told you that the mineralocorticoid receptor can be activated by both aldosterone and cortisol equally well. It's a mineralocorticoid receptor. And you might wonder, why is it that only aldosterone is not working? It's also cortisol is activating it. It's because most cells in the body have this enzyme that inactivate cortisol to cortisone, and cortisone cannot bind to mineralocorticoid receptor, and therefore it's impotent. Unless you have inhibitors of the enzyme, like licorice, or mutations of this enzyme as an apparent mineralocorticoid excess, cortisol is not that important. But there are 3 tissues in the body: monocytes, podocytes, and cardiomyocytes, the heart, the kidney, and the inflammatory cells, which don't have this enzyme, which means the cortisol is really the activator of the mineralocorticoid receptor, which is why we call them mineralocorticoid receptor antagonist. It's not an aldosterone antagonist. Spironolactone is not an aldosterone antagonist, it's a mineralocorticoid receptor antagonist. Now, what it makes it more interesting is, can you still activate the mineralocorticoid receptor in the absence of cortisol and the absence of aldosterone? In other words, you adrenalectomize the rat, and can you still activate the mineralocorticoid receptor? The answer is yes. If you produce oxidative stress, for example, through hypertension or infusing lipids or just going out and breathing polluted air, that will produce oxidative stress and it will activate mineralocorticoid receptor. And that's why when you're blocking the mineralocorticoid receptor, you're simply not removing the effect of aldosterone or cortisol, but also oxidative stress, etc. And therefore, it's no surprise that when you block these pathways, that you have an improvement in kidney inflammation, in cardiac inflammation, and also the vascular protection. You have a threefold magic that is happening by blocking this aberrant pathway. Now, the kidneys and the heart is connected, and you can see we only had one therapy till a few years ago. Before 2019, all we had was blood pressure control and ACE&ARB. That's all we could do. In 2019, we discovered SGLT2 inhibitors could protect the kidney. And a year later, in 2020, we discovered finerenone could protect the kidney. And they do it by complementary mechanisms. They work on the hemodynamics. That means that they are improving blood pressure and getting rid of salt and water. They are improving the metabolic derangements, but they're also acting on inflammation and fibrosis. And they do it in a complementary way. So instead of using one, we want to marry these three molecules. And that's where you will have the maximal benefit to your patient. I said just now that till 2019, we only had one molecule, which is the RAS inhibitors, losartan, irbesartan. They had done trials in 2001, and you can see on this slide that you have exposure to losartan, you have an improvement in cardiorenal risk, but there's a lot of residual risk that is still happening. Then we announced other trials, DAPA-CKD, Credence, EMPA-Kidney, and you can see on a background of RAS inhibition, the line looks more than like the residual risk, and we could lower the risk even more with giving people SGLT2 inhibitors in people who had albuminuria and kidney disease. But there is still residual risk. In other words, even when you're giving an SGLT2 inhibitor and losartan or telmisartan, you haven't abolished the disease. There's still residual risk. And here's a thing, is many people think, my patient is on dapagliflozin and telmisartan. Why are you wasting my time? You go away. I don't need another drug. You do, because you haven't taken away cardiovascular and kidney disease from these people, because you can see when people, even in a clinical trial, getting two drugs, dapagliflozin, losartan, telmisartan, what have you, you still have a residual risk. What it means is that if you have an albuminuric patient with type 2 diabetes, you cannot stay asleep. You have to do something about it. So what can you do? Are you going to say that, look, you have albuminuria, you are at a heightened risk for cardiovascular and kidney disease, and please go and get a better insurance policy? No, you actually can do something about it, because finerenone can reduce the chances of cardiovascular and kidney disease progression through improving blood pressure, through improving albuminuria, two things that you can clinically measure. And one thing that we have seen in animal models is inflammation and fibrosis. People often ask me, how do you know inflammation and fibrosis improving? I said, I haven't biopsied the hearts and kidneys of patients who have received finerenone, but I know from animal studies where they have done these preclinical studies that the inflammation and fibrosis improves in these patients when they get finerenone. And the way it works is that finerenone goes and blocks the mineralocorticoid receptor, as a result of which the downstream effects that you see with aldosterone, with cortisol, with hemodynamic stress, with the oxidative stress are blocked. and therefore you're producing the downstream benefits. Now, some people think that finerenone is an expensive spironolactone. I can just use low-dose spironolactone, and that should work just fine. And here's a comparison of spironolactone and finerenone. Spironolactone was a great drug. It was approved by the FDA in 1960. So it's a 65-year-old drug, and it was approved for the treatment of hypertension and patients with heart failure with reduced ejection fraction and subsequently resistant hypertension. What we have shown with spironolactone that it can reduce albuminuria, but we have never shown that it produces cardiovascular protection or kidney protection. In fact, a recent study which was done in the UK called BARAC-D study, it actually randomized people with who were older, 70 years of age on average, and they all had kidney disease, had GFR of less than 45. And they asked the question, if I give these people low-dose spironolactone, can I protect the cardiovascular disease in those people? And all they experienced was hyperkalemia and AKI, and they had to stop the study early, and they had no cardiovascular benefit. So how is it that spironolactone is so different from finerenone? Spironolactone is really a prodrug. It's actually metabolized to canrenone, which is the child of spironolactone. Canrenone is metabolized to thiomethylspironolactone, so you have a grandchild. And the grandchild is metabolized to 6-alpha-thiomethylspironolactone. So the great-grandchild has a half-life of 3 weeks, of 1 week, which means is that you give spironolactone for a few days, you will have circulating metabolites for many weeks, which means that it's a great antihypertensive drug, but the risk of hyperkalemia is huge. And that's why when we use spironolactone in people with kidney disease, the risk of hyperkalemia is unmanageable. The best example is from a trial that was just published a few weeks ago in Nature Medicine called BARAC-D trial, and it shows the risk of hyperkalemia is quite unmanageable. So what is so special about finerenone that makes it less hyperkalemic? And the answer is that they engineered that molecule. They made this molecule in the lab by which they could have a half-life of only 2 to 3 hours and no active metabolites. So it's a touch and go. And because of this and the way it acts on the mineralocorticoid receptor, it reduces albuminuria, but more important, it reduces cardiovascular disease, it reduces kidney disease. So this is more than a promise that you have a reduction in albuminuria, which you do see with spironolactone, but you don't see the cardiovascular and the kidney benefits in people with type 2 diabetes. So you might be wondering, what is the evidence that this drug is really working? And we designed this study about a decade ago. And the question that we asked was that, can we show in people with type 2 diabetes that this drug protects the kidney and also show that it protects the cardiovascular system? Now, this is very difficult to do because if you're wanting to see kidney disease progression, you have to see people with a lot of albuminuria and more advanced kidney disease. You want them to progress to dialysis. And if you're wanting to look at cardiovascular protection, you don't want them to progress to dialysis. You want to have microalbuminuria, as Dr. Sujay Roy pointed out. You're looking at people with identification of early endothelial dysfunction by measuring albuminuria, microalbuminuria. So we designed 2 studies. One was the Fidelio for the kidney, which had more advanced kidney disease, a lot of albuminuria, and a very early stage kidney disease, which had very little albuminuria, and we were trying to impact cardiovascular disease progression. And together you have about 13,000 patients in the 2 studies combined. 1,000 sites, 48 countries, it's a worldwide trial, and we are looking at cardiovascular and kidney protection. And when we look at these 2 studies together, because they are complementary studies, we could analyze the data together in the Fidelity program. Now, just to illustrate for you Fidelio and Figaro, Fidelio has a mean GFR of 44, which is pretty impaired compared to Figaro, which is about 68. And you can see that the UACR is much higher in Fidelio, 851 versus 312. Nearly 90% of the patients in Fidelio have macroalbuminuria, and nearly half the patients in Figaro have microalbuminuria. Very different studies because you're looking at people with early stage diabetic kidney disease in Figaro to demonstrate cardiovascular protection, and you're looking at late stage kidney disease in Fidelio to look for kidney protection. Now, we were doing this trial and we finished randomizing all the patients. We have 13,000 patients, and we looked at these data as a steering committee. There were about two cardiologists, three nephrologists on the steering committee, and one endocrinologist. And we sat around, I remember, in London, and we are looking at this data. It says, oh, we have age of 65, 15 years of diabetes. Blood pressure is fairly reasonably controlled, and everybody is on RAS inhibitor and 3/4 on statins. And we are scratching our head. Now we have randomized half these patients to placebo, half the patients to finerenone, and we want to show cardiovascular benefit and kidney benefit. And at that time, there were two studies announced. One was the VNFRON-D, which was looking at losartan, lisinopril versus losartan alone. And what did it show? More hyperkalemia, more AKI. They stopped the study. And the same time, Novartis was doing a study which was called Altitude with aliskiren, which is a direct renin inhibitor, and valsartan versus just valsartan alone. And that also had hyperkalemia, AKI. They stopped that study. And we are in the middle of doing these two large trials, and we didn't know, frankly, which way the camel will sit. At this time, there were two other companies that were developing non-steroidal MRA, Pfizer and Eli Lilly. Eli Lilly is in the town that I live in, Indianapolis. They were developing the drug, and Pfizer was developing the drug. And turns out they closed their program. They said, we don't want to do this anymore. And now you know why there's only one finerenone. There are 3 or 4 SGLT2 inhibitors because multiple people were in the race, but 2 people left the race. They actually had drugs, but they said, we are not going to take the risk. And we were blessed because we saw positive results. You had a 32% reduction in albuminuria within 4 months, which is what we saw in a phase 2 trial, but albuminuria reduction is not what you're simply looking at. I want kidney protection. I want cardiovascular protection. And that's when I realized the net clinical benefit. I'm not looking at some surrogate. I'm looking at a hard endpoint. What is also very interesting is that when you start this drug, you drop your GFR. That means you start this drug, creatinine is going to go up. Why? Because it's working on the hemodynamics. The GFR will drop, the intraglomerular pressure will drop, and therefore the blood pressure will also drop and the creatinine will go up. It happens all the time, and people get cold feet. They say, oh, stop the drug, creatinine has gone up. Wrong, don't do that, because if you look at these patients 3 years down the road, the people who continued the drug, they come out ahead. The placebo group drops. In other words, you're paying a price a little bit in the beginning, but in the long term, because you have an improvement in albuminuria, you will have a net clinical benefit on the outcome because of that reason. So don't stop this drug simply because you have an increase in creatinine. Now, how do I know that it's the improvement in albuminuria that is leading to the outcome? So we did something which is a causal mediation analysis. So you can conceptualize the study that you give a treatment and you have an outcome, for example, kidney outcome or cardiovascular outcome. And that could be a direct effect, or it could be because the patient has an improvement in albuminuria. So you measure the albuminuria from baseline to 4 months and see how much reduction the albuminuria has, and look at what happens down the road from 4 months to 3-4 years, however long you're following, and ask the question, how much of this benefit is because of reduction in albuminuria, and how much of this benefit is independent of albuminuria? The statistical details are irrelevant, But what we found was an astounding 84% of the improvement in kidney outcome could be attributed to the improvement in albuminuria. In other words, what it means is that USCR is a great screening tool, but when your patient comes back and you repeat the USCR and you have a large reduction in USCR, he says, you know, you were at a danger when I saw you 4 months ago. I have improved your USCR, and please continue to take this drug because we have evidence. I heard it from a talk from Dr. Agrawal, and he told us that there is an improvement in the outcome that you can experience. In other words, don't stop the drug. I've heard so many physicians say is that, look, I'm going to not give the drug anymore because USCR is now less than 10. No, 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 you don't want to do that. You haven't understood how the drug is working, because the drug is working on blocking the mineralocorticoid receptor, and the albuminuria reduction will go back to where it was if you stop the drug. So don't stop the drug, keep going. Now, one of the most dreaded complications of kidney disease is going on dialysis. Dialysis is terrible. And even in the United States, if you go on dialysis, you have type 2 diabetes, the outcome of that patient is worse than that of metastatic colon cancer. They don't survive very long. It's a terrible disease. When I look at finerenone in the entire program, I see that there's a 20% relative risk reduction for end-stage kidney disease. We're not just talking about reduction in albuminuria. We're talking about a fifth reduction in the risk of going on dialysis. Spironolactone can't say that, but finerenone can. This is different. This is an improvement in a hard outcome, a fifth reduction in going on dialysis. So when you see your patient say, look, you have albuminuria, your risk of going on dialysis is increased, but I have a medication that can reduce your risk of going on dialysis. It's going to be expensive. It's not a cheap medication. But if you take that, a fifth reduction in the risk of end-stage renal disease, let your patient decide if he wants that. What is more remarkable is that there's a fifth reduction in heart failure hospitalization. One drug, two benefits, the kidney benefits, the cardiovascular system benefits. Now, something I would like you to note is that in all these patients have type 2 diabetes and chronic kidney disease. How many people have kidney failure outcome? Kidney outcome. It's only 7% of the patients. You can see here placebo patients, 465 out of 6,500 patients have kidney outcome. And cardiovascular outcome, it's 939 patients have cardiovascular outcome. So we are dealing with type 2 diabetes and kidney disease, but the cardiovascular outcome is twice as common as the kidney outcome, twice as common. In other words, when you have a patient with type 2 diabetes and chronic kidney disease, you need to worry more about the heart. That patient is more likely to have cardiovascular death and heart failure hospitalization. And one thing that you might not know, this is from the Framingham Heart Study. They did this study published in 1984, Dr. William Cannell published it. What he showed was that if people had dipstick proteinuria, the crudest measure of detecting albuminuria, and they had an MI, they dropped dead compared to if they didn't have albuminuria. In other words, USCR kills you. USCR doesn't give you a second chance. Primary prevention of cardiovascular disease is the way to go. Now, I made a statement that you need to have a lot of albuminuria to protect the kidney, and this is what it shows. That, look, you have a lot of albuminuria, more than 300, you have protection, you have microalbuminuria, you really don't have kidney protection, which is very different from cardiovascular disease. If you have microalbuminuria, it simply suggests that you have endothelial dysfunction. You use finerenone, you will have cardiovascular protection. It's not dependent that you have a lot of albuminuria and then you will protect. Microalbuminuria will protect. In other words, this is a smart drug. It works early, it works late, it works on the heart, it works on the kidney. And in fact, when you use it in people with Figaro, you see a 32% relative risk reduction of heart failure, not just a fifth reduction, 32%. You start early, you have more cardiovascular benefit. People think about SGLT2 inhibitor all the time, and they asked us, oh, finerenone work because people were on SGLT2 inhibitor. So we analyzed the data, and we find that finerenone can improve UACR, whether patient is on SGLT2 or not on SGLT2. And the improvement in cardiovascular and kidney outcomes is similar regardless. Let's talk about safety. Now, all the safety that you can imagine with finerenone is based on mineralocorticoid receptor antagonism. I told you when you started the lecture, 3 effects of mineralocorticoid: salt and water, blood pressure, and potassium. And those are the side effects you get. Potassium, hyperkalemia; blood pressure, hypotension; and sodium can sometimes drop, hyponatremia, less than 1%. That's all the effects that you see, and they're all related to something that we are blocking. You're blocking the mineralocorticoid receptor. These are the expected side effects. You don't see any effect on A1C because this is not a diabetes drug. You don't see any breast enlargement like spironolactone because this is a selective MR antagonist. You have a modest effect on blood pressure reduction, but you have also the doubling of risk of hyperkalemia. Hyperkalemia was seen in 14% of the people compared to 7% in the placebo group. But what it also means that 86% of the people who you give finerenone will never experience hyperkalemia. So who are the people who experience hyperkalemia? More advanced kidney disease, potassium is high at baseline, people who have more albuminuria, people who are on beta blockers, and people who are not on SGLT2 inhibitors. Those are the risk factors that will produce hyperkalemia. But look at it another way. If you have microalbuminuria, normal kidney function, you're probably never going to experience hyperkalemia. In fact, less than 2% of the people who receive this drug stopped the drug because of hyperkalemia. Now, when we did the RALS trial, this was a spironolactone, and in people with heart failure with reduced ejection fraction, we had a lot of people prescribing spironolactone, and a lot of people got hyperkalemic. And when we published the fidelity analysis, people said just give it a few years, you'll have a lot of hyperkalemia. So we said, okay, let's just do a real world analysis, fountain and find real. And we had about 16,000 patients in the United States who had been prescribed finerenone. And what we find is a fifth of them have no albuminuria. That means that they improved. The reduction in albuminuria is about similar to what we found in the clinical trials, between 30 and 40%. And when we used it in combination with SGLT2 inhibitors, there was even a greater reduction in albuminuria and less elevation in potassium. And the risk of hyperkalemia was even lower than what we saw in the clinical trial. We saw about a 14% incidence of hyperkalemia. In this study, we only found a 1.3% risk of hyperkalemia. In other words, there's really not a whole lot of hyperkalemia that you're getting. Here's some practical tips. We have 2 doses available, 10 milligram and 20 milligram. 10 milligram is what you want to start when the GFR is less than 60. 20 milligram, you can start if the GFR is more than 60. If you're on 10 milligram, you want to titrate up the dose to 20 if the potassium is less than 4.8. That's what we need to do. I've seen a lot of physicians say, I just take the 20 milligram pill, I cut it in half and give it to the patient because it's an expensive drug. I want to do that. They say, well, we have actually looked at the reduction in albuminuria in the ARTS-DN trial, where we prospectively randomized them to 10 or 20 milligram of medication. And you can see with the 10 milligram, you get a 24% reduction in albuminuria. With 20 milligram, you get a 38% reduction in albuminuria. The question is, do you want a very tiny amount of albuminuria reduction or a lot of albuminuria reduction? If the drug is working through albuminuria reduction, the answer is just use the way that we used in the clinical trial. And when you use it this way, this is a complicated algorithm. All you need to remember is don't stop the drug if the potassium is less than 5.5. Keep going. And only stop it if the K is more than 5.5. All the guidelines now suggest that this should be in the treatment pathway of people with type 2 diabetes and chronic kidney disease. And in summary, what I would urge you to do is check USCR to detect the disease early, check it again to see if the drug is working, and if the drug is working, provide feedback to the patient that this is improving. This is the way you should be taking the drug. I was giving this lecture in Europe, and there were a lot of people in the audience that said, look, this is too complicated, make it simple. I said, there's just 5 facts about finerenone. Use it if the GFR is at least 25. Use it only if the K is 5 or less at baseline, and keep going unless the K is more than 5.5. And if you do it, you have a 5th reduction in heart failure, a 5th reduction in kidney dialysis. That's all you need to know. It's quite simple. Thank you very much for your attention.